of Medicine. I'm going to now turn this session over to them.
Thank you, Gertie. So we have a lot of information that we're going to get through today, so we're going to try to cover everything. So we're talking today about trauma and mental health during these difficult times. The agenda for today is to review symptoms and behaviors in children and adolescents who have experienced trauma. We're going to review a few evidence-based trauma-informed interventions that are available in the area, and then also discuss how COVID-19 and other current events have been impacting trauma treatment. The learning objectives for today are to describe the presentation of trauma in children and adolescents, again, identify evidence-based trauma-informed interventions, and then recognize related cultural, individual, and environmental variables that can impact trauma-related symptoms and behaviors in children and adolescents. So what is trauma? Trauma can be defined as an actual or perceived threat of danger which overwhelms a person's usual coping ability and impacts of functioning. So trauma can impact coping and functioning, and often the person exhibits trauma responses. A traumatic event is a frightening, dangerous, or violent event that poses a threat to a child's life or bodily integrity. Witnessing a traumatic event that threatens life or physical security of a loved one can also be traumatic. So even if they are not experiencing it themselves, if they're witnessing someone that they know or love going through a traumatic event, that can also be a trauma as well. So on the NCTSN, so the National Child and National NCTSN website, there are a list of different things that can be considered a traumatic experience. So physical, sexual, or psychological abuse and neglect. Important to note, it does include trafficking. Natural and technological disasters are terrorism, family or community violence, sudden or violent loss of a loved one, substance use disorder, refugee and war experiences, serious accidents or life-threatening illnesses, and military and family-related stressors. Something I wanted to focus on was COVID-19 as a trauma. We've been seeing an increase in families and children coming in for services because of COVID-19. There are definitely psychological and social effects due to the pandemic. Associated with the pandemic is an increase in distress, anxiety, fear, depressive symptoms, sleep disturbances, social isolation, and other chronic stress. Another thing is with all the frontline workers, a lot of kids are separated from their parents or family members because they are going into work. Something else that has been increasing is worsening of alcohol or drug misuse, and it just has been disrupting just day-to-day life with distance learning and isolating from friends and all of that. So that has been increased in treatment, and at least in our center, I'm assuming everywhere else as well. Something else I wanted to touch on was racial trauma. The topic for today was just kind of on all the difficult things that are going on in the world today. And these are two major things that are just kind of in our face all the time. So racial trauma is a form of race-based stress, and it refers to people of color and indigenous individuals' reactions to dangerous events and real or perceived experiences of racial discrimination. So this can include threats of harm and injury, humiliating and shaming events, and witnessing racial discrimination toward other people of color, indigenous individuals. So we've also seen an increase in racial trauma coming in through our center, especially with everything that is going on in the world. It's kind of unavoidable. It's on social media, it's on the news. Kids have access to it pretty easily. And so all the videos of police violence and things like that, kids are getting vicariously traumatized watching these things. And it's really been impacting our kids that have been coming in here. A lot of the kids that are experiencing racial trauma have similar symptoms to PTSD, such as hypervigilance, flashbacks, nightmares, avoidance, and other somatic symptoms. Children and youth inherit their family history of institutionalized disadvantage. And so even with that, and then everything that's going on in the world today, it's just, we've been seeing more and more of it. This isn't anything new. I think that this is something extremely important to consider when you're treating trauma. And fortunately, the youth we care for today also have inherited intergenerational strengths and resilience that also impact long-term outcomes. So the prevalence of childhood trauma, 2/3 of children report at least one traumatic event by age 16. So if you think about it, like 2 and 3 kids have a traumatic experience. So it's really important to understand, like, how can I notice if a kid has experienced trauma, if there's some changes. We're going to go over those things and like signs that you can look for in youth today. So 8 to 12% of American youth have experienced at least one sexual assault. 9 to 19% have experienced physical abuse by a caregiver or physical assault. 38 to 70% have witnessed serious community violence. 1 in 10 has witnessed serious violence between caregivers. 1 in 5 has lost a family member or friend to homicide, and 9% have experienced internet-assisted victimization, so bullying online with social media and things like that. So if you look at the numbers, trauma is really prevalent, and it's out there, and so it's really important to notice and be able to figure out like what to look for in our youth. All right. So something to keep in mind as I'm going over signs of trauma with the different developmental ages, this is not every single sign of trauma. So these are like the bigger ones that you might notice, but if there are any like things that are kind of out of the norm for your child or the child that you're working with, then that's something important to explore as well. But for preschool age children, some signs of trauma are fear of being separated from their parent or caregiver. At preschool age, like there is some separation anxiety. However, if it is more than a normal, like a typical preschooler, then that's something to kind of consider. They cry or scream a lot, they eat poorly or lose weight, and have nightmares. For elementary aged kids, they may become more anxious and fearful. They may feel guilt or shame. They may have a hard time concentrating or have difficulty sleeping. Something to note is that in elementary students, a lot of times these kids are misdiagnosed with ADHD. And so a lot of ADHD symptoms can be partly based on trauma experiences as well. So really asking those questions to explore, like, is this just ADHD symptoms or is there something else going on? Especially if the child is acting outside of like how they normally act and they're being more hyperactive and having those, some of those like being distracted easily, things like that, then making sure you're differentiating between ADHD and PTSD. Signs of trauma in middle and high school aged youth. So they may feel more depressed, they might isolate and feel alone, they may develop eating disorders or self-harming behaviors, they may begin using alcohol or drugs or become involved in high risky sexualized behaviors. Again, this is not everything, but a big sign I feel like for middle and high school that we hear from our teens directly and that we see is that they do isolate more, especially if you're noticing a kid that's like normally pretty social and like has friends, like, and then all of a sudden they're not engaging in anything they used to like to do, and kind of alone and like isolating themselves in their room, not really interacting with family. Those are some big signs there. So what can we do to help these youth that are experiencing trauma? So I'm going to touch on several evidence-based trauma treatments that are effective in treating trauma. So trauma-focused cognitive behavioral therapy, child-parent psychotherapy, alternatives for families of cognitive behavioral therapy, combined parent-child cognitive behavioral therapy, and parent-child interaction therapy. I have a slide for each of these. I'm going to rush through this because I know we don't have enough time. However, my slides will be available after if you are interested in any of these treatment models. So TSCBT is designed for kids aged 3 to 21. It is like the gold standard of trauma treatment at this time. And it's for kids experiencing emotional and behavioral difficulties related to a traumatic life event. Typically, it's 12 to 25 sessions long, and it's about 1 to 1.5 hours per session. It's easy to find a trauma therapist through TFCBT. If you're nationally certified, you can easily search them online. So it's easy to find online. Child parent psychotherapy is designed for kids 0 to 6 years old who experience trauma and are exhibiting mental health, attachment, and or behavioral problems. This incorporates the parent and the child. And in CPP, the parent, there's a lot of parent-focused sessions in the beginning to really stabilize the parent so that they can support their young child through their trauma experience. It's typically about a year long, and the sessions here, again, are 1 to an hour and a half per session. So AFCBT is designed for children 5 to 17 that are actively occurring family aggression, conflict, and coercion. So this means basically, like, if there is a kid between 5 to 17 years old, there's a lot of like parent-child conflict. There might have been a history of like physical abuse within the family, and they're working on like strengthening attachment and things like that. So those are the kids that typically benefit from this treatment. It's about 20 sessions long. And again, 1 to 1.5 hours per session. So combined parent-child cognitive behavioral therapy, CPC-CBT, is designed for kids 3 to 18 years old and their caregivers. Families where caregivers engage in coercive parenting strategies, they may be using corporal punishment, things like that. This provides them alternatives and provides support with the parent and the child. This is all 16 to 20 sessions and an hour and a half per session. Parent-child interaction therapy is another treatment modality that is effective in treating trauma. This provides a lot of structure for the child and really focuses on managing those problematic behaviors. So this is designed for children 2 to 7 years old, and it really helps with managing oppositional defiant and other externalizing problem behaviors. And like I said, there is research showing that because you're focusing on like encouraging parent interactions with the children, and their therapist is coaching the parent in this treatment model, they become more confident in interacting with their child. And because the child knows what to expect because there's routines and structure with this treatment, it minimizes trauma symptoms in children, which are usually externalized behaviors. This is typically 14 to 25 sessions, and the sessions are about 1 hour each. All right, so COVID-19 and police violence, I just wanted to highlight some impacts on treatment. These are the two biggest things I feel like I see in treatment, and Dr. Varon's probably going to elaborate a little more on about his practice as well. But COVID-19 and police violence has really exacerbated symptoms. So kids that have been coming in for trauma treatment with PTSD symptoms or depression or anxiety, the things that are just going on in the world today are really increasing some of those symptoms. And so a lot of focus has been stabilizing again, and actually has impacted trauma because this current traumatic experience is kind of putting a pause on like whatever other traumas that they initially came in for. Like I mentioned before, more youth are acknowledging racial trauma. Although as mental health professionals, like we've heard this, we're treating kids that or families that have experienced racial trauma, but it seems to be more up and like up front, and like in like kids are more aware that this is an actual trauma. And so it kind of, in my experience, has brought like some relief that like, oh, this is not just me making this up in my head or like I'm overreacting, but this is a legitimate traumatic experience as well. The lack of answers and the unknown of the pandemic, and just like, am I going to be safe if I go outside and I get in trouble, right? Especially if you're a Black teenager, Black male teen actually. And these are conversations that have been coming up in treatment more frequently lately, really talking about safety. What can you do? How can you stay safe during the pandemic? How can you stay safe if you're out and about? Things like that. Telehealth. So since the pandemic hit, many of us have switched to virtual sessions. This has impacted treatment just because some families don't have access to devices, or they are having trouble with Wi-Fi. Sometimes like they just don't want to be seen on camera, especially with younger ones. They have a hard time sitting still for more than a few minutes. And so it does impact treatment because it's not as effective as like being face to face in the moment, being able to play with them and using some play techniques and things like that in treatment. We have seen a regression in progress in treatment, like I said before, because of everything going on right now. It seems like there's kind of, we hit a plateau, or like things have been exacerbated. And so we're, making sure that we're working with our kids and families to continue to maintain routines and structure so that we can progress in treatment. With distance learning, kids are on Zoom, Google Classroom, whatever, all day long. And so my experience has been that a lot of times, like even in the summer, they've been willing to meet with me on Zoom. And now it's like, oh my God, Miss Gloria, like I'm on Zoom all day. Can we take a break this week? Things like that come up. And it's completely understandable. I'm on Zoom all day. I feel it. It is very tiring. And so distance learning has impacted it. Kids have been more frustrated. They feel like they're not interacting with their friends. They're not able to see them. And so those kind of things have impacted treatment as well. And then lack of childcare has impacted treatment, because when parents bring their kids in for treatment, we have like a waiting room, or like they're in school, something like that. And so especially if there's multiple siblings in the home, there are places that for them to be when they come in for treatment. However, with the lack of childcare, it's been like siblings popping in and out of session sometimes, or the parents have a hard time and they can't sign on for their weekly appointments, things like that. And so all of these things have been impacting treatment, and we've been having to think outside the box and be creative to engage our families and children to like participate in treatment, and to really still talk through and process their trauma experiences despite all of these impacts. So how can we help? So these seem kind of like, oh yeah, I try to do this anyways, but I wanted to really go through these because this is extremely helpful for any youth to help them feel safe. So you make sure you try to make them feel safe, like normalize some of their experiences, like their reactions, things like that. Act calm. As sometimes when we hear things, we react, and like we have a hard time like managing our own emotions. And so making sure we're regulating our emotions and acting calm at least, so that the child feels safe to actually talk to you. Maintain routines as much as possible. Like again, with distance learning and everything going on in the world, there has been some struggles with maintaining routines. Things have been up and down, but trying to maintain a routine as much as possible is extremely helpful. Help children enjoy themselves. So if there are different things that they like to do and they're prevented from doing because of the pandemic, like maybe it's some sports activities or whatever it may be, there's creative ways to kind of figure out how you can get your child to still engage in those activities. So playing with them yourself, like kicking the ball around outside, those kind of things, baking, cooking together, those are all things that are enjoyable. Share information about what happened. I think sometimes as mental health professionals or parents, whatever it may be, we try to shield our youth from, negative information, or like, oh, I need to protect my child from this. However, with access to social media and just having smartphones, this information is gonna be out there for them anyways. And so if you can actually have an honest conversation with them, developmentally appropriate, obviously, that is actually helpful, instead of like trying to completely try to shield them from any information, because they will hear about it from friends or social media. Pick good times to talk. If your child is moody or hungry or did not get a good night's sleep, probably not the best time to talk to them about things that are going on right now and how stressful it can be. So making sure that they're in a calm state where whatever you say is actually going to be heard and you can have an effective conversation with them. Prevent or limit exposure to news coverage. Something that I've talked about with several parents is that just because they want to know what's going on, they just have the news on in the background all day, especially since everyone's working from home. However, like, yes, that keeps you informed about day-to-day things. However, for some kids, based on their ages too, that's not the best. They might overhear things, they might have more questions. And again, if you're actually openly having these conversations, that is helpful, but also trying to prevent or limit some of those exposures, especially to the videos and things like that of the police violence that are uploaded pretty frequently, because kids can be vicariously traumatized. So another thing to keep in mind is to understand every child copes in different ways. I went over different signs of trauma in kids, and those can be different based on who the kid is. Same with coping. Kids cope differently. Some kids hold it in and they seem fine and they're okay, but really they're really struggling inside. Some kids are more externalizing, and so you see all these aggressive behaviors, or they're just moving a lot, things like that. So making sure that you know your child and who you're working with, and making sure that if there are any kind of things that are kind of outside the norm, then checking in on them about that. Listen well. So we all have a lot going on, and I think we get distracted easily, but really being present and like letting your child know that you're listening to them. So like eye contact, being close, making sure you're looking, and, the nonverbals, like shaking your head or like saying, yeah, of course, that also helps encourage kids to talk. Help children use coping skills based on their ages. Some younger kids, it might be helpful to do coping skills together, practice together, encourage them to use it. In sessions, you may incorporate the parents to come in and like give them homework to do coping skills together. And then acknowledge what your child is feeling. So validation is extremely important. Validating isn't agreeing with their behaviors, right? So if your child is just super stressed out and acting out, you're not going to say, great job acting out. Instead, you're going to say, I understand why you might be acting out, especially since there's so much going on right now and you're stressed. You're just letting them know you understand why they're doing it, not stating that you're okay with what they're doing. And then you can talk through that. And last but not least, know that it's okay not to have an answer. I think as mental health professionals or just adults, like we often feel like we have to have answers for everything. And I think instead of acting like we know everything, sometimes it's really validating for the child to be like, oh, you don't know either. And you guys can explore, talk about that together. And so that's okay. Being honest is better than just trying to act like you know everything, and it actually makes the kids feel more comfortable. So that is everything. I think I went past my time, but that is all. We're going to have a Q&A session at the end, but this is my contact information if anyone would like to reach out. And I believe, I think Mackenzie will have this information sent out as well. All right, Dr. Varon.
Yes, just so everyone is aware, we are recording these sessions, and the recordings will be posted to our website starting in November. Okay, Dr. Varon?
Yes. Okay.
Perfect.
This here. There we go. All right. Good morning, and thank you, Gloria. And I learned a lot from your session there about the various therapies and really good suggestions and so forth. What I'd like to do is try to talk a little bit more about some of the stressors with COVID-19, and then my segment will be focusing on some medication strategies. Okay, so all right, so so there may be some overlap, so forgive me. So a number of emotional stresses that one could imagine, but keeping in mind also, as was mentioned, that if a child has pre-existing psychiatric symptoms or a psychiatric condition, it may exacerbate these stressors, may exacerbate those symptoms, but also a child can also have kind of a new onset of what we'll call emotional dysregulation or behavioral. So some of the things that we're all dealing with, as well as our children, cancellation for planned events, life cycle events, religious events, celebrations. Sadly, if there's someone passes or you have an ill relative, not being able to see them or to participate in the grief rites of passage that are there have been very difficult. The children and the parents are dealing with less structured settings, and many children are very sensitive to that. Children may be not only concerned about themselves getting ill, but what if the parents get ill? Financial stress, housing stresses, big one, lack of peer interaction, and also being removed from social engagements. That can also lead to a lot of moodiness and acting out in kids. We've all gone through changes in routines, certainly parents with school-age children having to juggle between parenting, being a teacher, so to speak, and job can be very stressful. And of course, the social distancing requirements. And one of the things that I think kids are very in tune to is some children have less restrictions on their social engagement than other children. Different families have different ways of approaching how they want to deal with the pandemic. And that can lead to children feeling isolated, left out, if their parents or their family situation is more protective. These can all be very stressful. By the way, sorry about that, there's a lot of loss that children are experiencing, not just people passing away, but caregivers may not have been able to engage as much. If there's a babysitter or a grandparent that has helped, they may have experienced that that person no longer is involved. So there's a lot of changes and a lot of loss that that children are going through that can add to their symptoms. Vulnerable populations, again, people with previous psychiatric conditions, children with developmental disabilities, learning disabilities, medical conditions, and of course, if they already have a history of trauma. But I'd also like to point out that the parents and caregivers, that they also, if they come to the table with any of the conditions that I've just described, they can be vulnerable also of having their own psychiatric distress. If they're a single parent, if they've dealt with a history of substance abuse, these populations are very vulnerable. And of course, parents that don't have any of these pre-existing conditions can be extremely stressed. Some of the things that parents are dealing with, in addition to what I've already mentioned, understandably, they can be feeling overstretched, overwhelmed. Isolation is a big one. Underappreciated. They may feel not competent with all the new roles that they have to take on, and these can contribute to a parent or caregiver's own symptom deterioration and stress. And one thing I'd like to point out, which I always point out when parents come with their children for treatment, is that the parents / caregivers, they're more likely to take care of the family members than of their own selves, and they may forego their own psychiatric or medical care. And I'd like to point out that please, parents or caregivers, if you can, be attuned to your own needs and don't hesitate to reach out for your own support, because that will trickle down to your children as well. The oft recited example of when you're in a plane and they say, if we lose cabin pressure, put on the mask yourself first before trying to fit your child with a mask. So parents, caregivers, please look after yourself, because that will also be helpful for your children. Now, so I'm going to focus on medication strategies. However, just keep in mind that the primary treatment intervention for stress or trauma, and not everyone with stress requires treatment, but the stress can certainly turn into a situation which is consistently and significantly getting in the way of things, and treatment should be accessed in the variety of ways it could be. The standard of care is what we call the cognitive behavioral strategies that Gloria pointed out and described. Medications are an adjunct. They're not a be-all, they're not an end-all, but it may lower the intensity of the volume of some of the psychiatric symptoms that can come along with these conditions. So who are the people that prescribe psychiatric medicines? Well, child and adolescent psychiatrists, of which I am one. We are not so many of us in the country. And so there can be a difficulty time finding one. But also, developmental pediatricians or behavioral pediatricians are trained in utilizing these medications. Primary care pediatricians have some of these medications at their disposal, although many of them, because they can only know but so much, they have to know a lot about a lot of things. They may feel uncomfortable going beyond one or two choices and may want to refer to a specifically trained individual. But nonetheless, primary care pediatricians can also prescribe these kind of medications. And more we're seeing specifically trained clinical registered nurse practitioners who are also evaluating dispensing psychiatric medications. Now, today, many of us are utilizing telemedicine, some exclusively. I haven't seen a live patient since mid-March, but I'm very grateful for the opportunity to use telemedicine. And there have been changes in state and federal laws and insurance reimbursement that has allowed the rollout of telemedicine so it can be used during this time. I understand that years and years of lobbying and legislation has been condensed into several months during COVID-19 to make these things available. In fact, even if video conferencing is not available, I believe Medicaid and Medicare and I believe private insurances are also allowing telephone medicine to be reimbursed if video conferencing is not available. And we're all hoping that these changes will continue to support this beyond the COVID-19, because for various reasons, telemedicine may be a really good intervention where going to the clinic may not be so easy. Now, one of the very great difficulties, and I'm speaking to the choir here with NAMI, but caregivers and parents, I'm sure, have experienced access to care difficulties. If you're a non-established patient, you don't have a relationship already with a mental health provider, getting to see one of us, a therapist or a psychiatrist, can be very difficult. And so what I'm going to suggest is some ways that you can find your way to a mental health resource. Certainly contact your pediatrician. They're the frontline people who are engaging with your child's primary care. They will have a list of people they refer to, either agencies or private practitioners, or if you're already seeing a therapist, they often will work with a group of, either if they're in an institution like Gloria, and they have psychiatrists on staff there. If you're in a mental health institution or organization, they may have psychiatrists, but also if you're seeing somebody privately, they will often know of doctors that are available. You can consult if you have private insurance or medical assistance or Medicare, there are numbers that you can call to find out who is in the network. Now, unfortunately, there's a lot of, they call them ghost networks, where they'll say, we have all these doctors who are on the network, but you call them and they're either not taking patients, they've moved, they've died, they what have you, and it's been a whole thing in Maryland and other states that these logs are not really kept up so well, more in the private insurance than the Medicaid insurance. And so you may be in for a lot of telephoning and trying to find, but keep up with it. Now, in Baltimore area, of course, we have Johns Hopkins, University of Maryland, and Shepherd Pratt that have outpatient centers. In other communities, Shepherd Pratt has a number of affiliated agencies throughout the state of Maryland. And so you can find something there. You can also call your county Department of Mental Health. We'll probably have a child branch of mental health, but if not, first start with the local health agency and they can refer you to mental health and they can get you to services. And of course, NAMI is very helpful in connecting people. Now, let's go to medications. So the only medications that are FDA approved for PTSD, and this is in the adult population, are Zoloft or sertraline, Paxil or paroxetine is generic. So we're looking at what we call off-label use. These off-label means that the medication, while not brought to market and approved specifically by the FDA, can be prescribed. In the United States, if a medication has an FDA approval for something, it can be used for any condition that the physician deems appropriate. And that is called an off-label use. So for example, I went to the dermatologist with my son. He had a wart. The laser didn't work, and they prescribed I think it was Zantac or a gastrointestinal medicine. I'm like, well, wait a minute, that's for stomach conditions. I said, no, it works for the wart, and actually it worked quite effectively. That's an off-label use. And in psychiatry, we use a lot of medications that are off-label. There are some that have what we call the pediatric indication, but if you look it up online, medicines that are prescribed might be said online, not studied and used in kids because it's not FDA approved. But it's very common practice for physicians, clinical nurse practitioners, to prescribe off-label. And of course, always feel free to ask your practitioner about side effects, uses, why do they choose this, etc. Pick our brains, that's what we're here for. Now, typically used medicines in the PTSD medicines are what we call SSRIs, serotonin reuptake inhibitors. And those medications are commonly used for depression, anxiety, generalized anxiety, major depression. So Zoloft, Prozac, I've listed a number of them there. We don't generally use Paxil in the child and adolescent population. Sometimes it is used, but the ones that I list here are the more common ones. And so we do use them for PTSD related symptoms. Now, other agents that are used are blood pressure type of medications. Again, going back to FDA off-label use. There's a medicine called guanfacine that is a ADHD medicine, also used for tics and Tourette's disorder, but that can also lower some of the mood reactivity that we can see with PTSD. Prazosin is another blood pressure kind of medicine that's used for nightmares and sometimes PTSD-related symptoms. And propranolol or atenolol, they're old blood pressure medicines. They can be used for stage fright, migraines, rapid heartbeat, but they can also be used for the irritability and mood reactivity, though not as commonly for PTSD. Now, sometimes if you go and your child has severe mood regulation, either resulting from a mood disorder or PTSD, sometimes anti-seizure medications are used, or what we call neuroleptics or antipsychotics. Those are less likely for that particularly, but I'm putting it out there is because that is a group of medicines that sometimes we use when some of these other medicines are not helpful. Now, I do want to bring to mind that, you know, with any medicine, of course, can come a side effect. Now, it's not on this slide, but I want to point it out. Any of these medicines can cause sedation. Any of the medicines can cause activation. Any mental health medicine can have an equal and opposite effect than that which we intend. So an antidepressant can make you more depressed. An anxiety medicine may take away the good anxiety. The child may take excessive risk. We call it activation, disinhibition. So if your practitioner gives you a medication and your child within the first week or two, because a lot of times that's when it happens, does not seem like themselves, they seem more irritable, or you feel like this isn't right, please reach out and call your practitioner, because just like, you know, we try to help the brain symptoms, sometimes we go too far unwittingly. Or again, sedation, it's another one. Sometimes there's changes in appetite. So if you have any question, please let your practitioner know. Now, another piece that may be getting impacted, either if you have a stress, PTSD, or just because of all the chaos going around or disruption, there can be trouble with children and adolescents falling asleep. Now, again, there's what we call sleep hygiene. I won't go over it here, but there's a number of good sleep habits, which you probably know intuitively. You probably harangue your kids to get off the screens an hour before sleep. But let's say, despite your best efforts and things, the child just has trouble going to sleep and all the supportive things aren't working, and it's getting in the way of their waking up too late, they're irritable, they're tired, they're fatigued, and you need to get them to sleep, because that's a treatment also. Please speak to your clinician about any of these options I'm going to go through. Some are over the counter, some are prescription. Again, there's no FDA-approved medication for sleep disorders in pediatric psychiatry, but I'm going to list what we use. Well, lots of people talk about melatonin, take it about an hour or two before sleep. It's a natural hormone that we make. We all use it, and it's very common. The problem, I'm not really sure. It does have some hormonal implications, and so please speak to your pediatrician or psychiatrist, nurse practitioner about the long-term use of it. There's no thing that is that's come down and say absolutely not, but like any medicine, even though it's over the counter, you want to be cautious and find out the risk versus benefits. But it is very common. Also, Benadryl. A lot of people take Tylenol PM. The PM part is Benadryl. So I'll tell people, do the Benadryl without the Tylenol, because you don't need the Tylenol to go to sleep. It's just really good marketing. Prescription aids, clonidine, That's an anti-ADHD medicine, very good for falling asleep. It's an old blood pressure medicine. Trazodone, an old sedating antidepressant. Mirtazapine, an old sedating, well, it's a current antidepressant, but very sedating. Hydroxyzine, that's like a Benadryl. It's also by prescription. We don't generally use FDA-approved medicines in adults for kids, like Ambien, Lunesta, Sonata. Usually we can get at it with the things that I've mentioned. Okay, a couple of other things, and then I want to go to some resources. In terms of supports, again, parents, individual therapy is very important, but as Gloria pointed out, there's a lot of parent support and parent-child therapies. Feel free to reach out to us or your practitioners or people to get some ideas, because a lot of times you're the people helping to manage the stress of the child, not just us therapy people. And so parents need support and training too. Number two, in terms of supporting the child, I bring up with parents, if families have a connection to a faith tradition or a strong cultural background, I mean, any of the faith traditions probably, I'm sure, speak to how do we get through crisis? How do we get through stress, difficult times? And can this be a teachable moment for parents in implementing their world vision of faith or the world and your worldview, whether it's faith-based or natural-based? But this can be a very good way of imparting in your child your worldview or your legacy of where you've come from, to how other generations have gotten through stress and strain. I had a colleague of mine who was a South Vietnamese doctor who had gone through the concentration camps in South Vietnam during that conflict. And he said what got him through the trauma of the camps was talking about the learning from the Holocaust survivors. Okay, and so tap into that and see if that can help. There's some resources I've listed here. The American Academy of Child and Adolescent Society, aacap.org, has things called Fact for Families. They can be very instructional. And here are the references I've utilized in my talk today. And thank you so much. And good luck to all of you, and I'll be available for questions.
Perfect. And Dr. Varon, if you just want to go ahead and stop share screen, we'll move on to the Q&A.
Yeah.
Okay.
Perfect.
Thank you both for that session, because it was so informative. We have several questions, and a lot of the questions that we have, you really have touched on. So maybe if you could go in a little more. The first question was, how are the impacts of the fragmented back-to-school process impacting access to services for Maryland students?
I can touch on that a little bit. So I did mention that in my presentation a bit, but actually having distance learning, there actually has been some positives, is that a lot of schools are giving our kids laptops or devices to use for the distance learning piece. So access to mental health services has actually increased, because a lot of my families use those school laptops or the devices that they were provided through the school, so then they can attend our appointments more regularly. So that is a benefit to that. And like I said earlier, because they're on Zoom and video calls all day long, there has been a decrease in wanting to talk to us for an hour a day, or an hour a week. So we do see a little bit of a downside in that, but there has been an increase in access because they do get those laptops and devices from the schools.
I would, to piggyback on that, on the downside, what parents have experienced, first of all, and I think Gertie, you had mentioned about ideally providing services for children in the schools. What they don't have access to is, unless it's online and so forth, is the ready access for a psychologist or a social worker who is on site. The parents, children with learning disabilities or developmental disabilities, in particular, both of those, have not the access to the instructional aid that they might get, or the learning specialist. Their learning disability may preclude them from accessing the Zoom video that everybody, or Google Classroom, and that's been very hard. And so my children with developmental disabilities or learning disabilities, while everybody tries, it's been very hard. And some parents have gone to providing through an individual tutor that somehow they are able to access. And so I have an autistic boy, just met with the mom yesterday, and typically gets an instructional aid. Well, you can't come to the house. He's very dutiful in going to the Zoom class, but so they have an instructional aid online next to him. But we all try, but it's very hard. In fact, some of the private schools that have dealt with the kids that have the learning disability program, they're going into school where a lot of kids are going on Zoom. But in the public school, it's been very hard for parents. And I hope after this is all done, society will have a much greater appreciation of what teachers do, because parents are learning firsthand that that's really a profession. It's, you're not just a smart person giving over stuff. That teaching is an active profession that we're really, we're all trying, but kids are losing out. And so what I'm trying to say is that that there has been a lack or a diminution of some of the services that for some of the more challenged children that parents are trying to supplement.
Thank you both. Another question was, and again, this was really covered, are telehealth services available for minors? And so we do know they are, but can they access them without parental consent?
Well, Gloria, I'm going to defer to you because I don't know the legalities of that.
Right. So you definitely need parental consent to actually start services. Once you get that all squared away and all the consent forms are signed, we usually do a diagnostic interview that includes the child and the parent or the caregivers. However, based on what it is that we need to work on, especially with our older teens, they do want some privacy and they want to talk to the therapist alone. We are mandated reporters, so we talk to them about confidentiality and what mandated reporters are required to do. But they do have access to mental health providers, and they can request to speak with them one-on-one. So I highly encourage parents and teachers and whoever else to talk to kids and let them know that that is an option. And most therapists are pretty upfront during the first time that they meet, like how does a family want to work on the goals, right? So if the kid is wanting to spend one-on-one time, we do keep the parents informed about like what is being worked on, but with confidentiality, the kids do feel safe to actually talk about things that they're going through as well.
Thank you.
Gertie, can I just add something back on the school piece I wanted to tell our listeners? One of the things that I've learned from my parents about the schools is while there are obvious challenges in providing services, the IEP, the individual, the IEP teams that kind of help with providing services for disabilities, they, by and large, have been very open to if the parent proactively asks. Don't assume that the IEP is going to guess what you need. I would encourage parents to reach out and ask, partner with, discuss, and see, because, I've been surprised pleasantly of how accommodating they have tried to be for the engaged parent. And so don't wait for the school to provide it for you. Reach out and ask. So.
Right. Okay, so that leads us into this question. Are there resources for parents or caregivers to access that can help support kids during this time? I know, Dr. Varon, you were sharing a couple things about faith-based, tap into that area, but are there other areas that parents and caregivers can tap into to get support for their kids?
Okay, I'll try that. Well, there are a lot of, it depends, of course, where somebody lives. So a couple of ideas. First of all, the national organizations, for me, the American Academy of Child and Adolescent Psychiatry, aacap.org. It's on one of the PowerPoints there. And they have lots of resources in terms to read about. How do you help? They have, videos, about lectures about this, and lots of information. I'm sure the American Academy maybe of Pediatrics has something. So that National Association of Social Work probably has. So those national organizations. I think reaching out to the governmental agencies. So again, the county or state. I know that in Baltimore County, we have Department of Mental Health, and there's a subsection for children. They can reach out there. Faith-based, I guess what I'm going to say is reach out. And Gloria can speak more specifically about Kennedy Krieger and all the things they have, but reach out, ask. This can be very isolating. Find out who your supports are. Parents can speak to each other. They know stuff. I refer them to NAMI all the time because you guys, we're hired hands. You guys been there, done that. Reach out. Okay.
So earlier on, I mentioned NCTSN. So, and then I like completely blanked on what that stood for because I'm so used to just using the acronym. So it's National Child Traumatic Stress Network. So nctsn.org has amazing resources specifically about trauma. They recently uploaded a bunch of stuff about the pandemic, as well as just like the things that are going on in the world with police brutality and things like that. So there's different fact sheets and like tips for teachers, for parents, for mental health professionals, and it's broken down and it's really easily accessible. And you can like print it out, you can share it with other people, and it's like things you can do even if you don't have a therapist or a mental health provider, right? So it's I always direct people to that, and their handouts are pretty easy to read, and the tips are really easy to follow. And so if you need like something right away, I would say take a look at nctsn.org, and there are so many different things on there.
Okay, thank you. I just want to let those attendees who are sending in questions to know that if we don't get to an answer for you, you will get something later. So hang in here with us. This question is, how can we better address trauma related to the pandemic in remote settings?
I mean, so again, like, unfortunately, because the isolation and like a lot of us aren't seeing clients on site, it can be isolating and it can be kind of frustrating if you can't find resources right away. So again, I would say nctsn.org has amazing resources on there that you can do as a parent with your child, or if you're a teacher, you can pass that along to the kids' parents that you're working with. And those are things that you can do without a mental health professional. And with, even if you are remote and you're not able to access people, like another thing is with telehealth, a lot of therapists are available via Zoom or whatever platform they're using. It's HIPAA compliant. You don't have to worry about all that. And so there are ways to access it. And if you need more information, like Kennedy has really great resources as well. Yeah, please feel free to reach out or check out NCTSN website.
One of the things in terms of rural settings, in addition to what Gloria mentioned, is if a broadband access is not available to certain areas, we've read about that not only in the cities, but I presume also in the rural areas. Insurances, again, I think medical assistance, I can't speak exactly for insurance private. I think I'm correct, I'm not sure, but telephone also may be reimbursable from a insurance point of view. The other piece would be that, again, in rural counties, schools, if they call their school resource, their guidance department, I bet you they have certain resources that are more local to where they, in the rural areas. If there's a local mental health clinic, if you don't want to be or can't be a client there, they probably have a list. And so I would start local. Pediatrician, the primary care physicians, they're probably a little overwhelmed at the moment, but reach out to your primary care doctor. They're tied into different networks locally. And so I would say, reach out to your local people that you use all the time for healthcare, what have you, or schools, and they will probably be able to point you to some resources there.
I want to add something too. Like, Kennedy is a very big organization. So like if you are living further away, and like before the pandemic, like we would probably require you to drive in, we are more flexible with providing services to people that live further away. And with all the grants and the money that's out there, you know, some of the bigger organizations do provide our families with tablets if they aren't able to have a, you know, their phone's not working or something like that. So, I mean, at Kennedy specifically, we have sent out tablets or like hotspots and things for families that aren't able to actually come in weekly for appointments and that are lacking those like tech resources. So if you call like a bigger institute or hospital, sometimes they have those grants ready. And so you can ask them like, do you guys provide like hotspots, or do you provide like devices for families? Because there are places that do. So just keep that in mind as well.
Good information.
If I can throw in another resource, not necessarily for the trauma and stress, though it's all related. There's a lovely organization called Depression and Bipolar Support Alliance, D like David, B like boy, SA.org. That if there is, you know, family member that has a loved one or children with a mood disorder, certainly would be impacted by stress and trauma. They have a lot of resources. They even have support groups locally. So dbsa.org, a lovely resource.
Thank you all. Thank you. Mackenzie?
Perfect. So thank you so much for attending this session. Head on over to our main conference session, and I will put that link into the chat. And join us for a guided meditation with Shepherd Pratt. See you all there.
Thank you. Thank you.
Thank you.
Thank you. Bye-bye.